All
Okay.
right, please proceed.
Okay. Thank you so much, Paul. Yes. Thank you so much, Paul. Are you guys able to see my screen?
Yes, we can.
Okay. Thank you. Thank you, Paul, and the Ultrasound Care Foundation for having me present on one of my favorite topics is obstetric image optimization from the basic to advanced. And again, thank you for having me. Glad to be a part of these series that Ultrasound Care Foundation is doing to really, enhance education, how we could provide that open access to everyone around the world, especially those who are imaging. Okay. All right. So our goals is just to review the basic 2D image optimization controls and how they affect your image, apply tips and tricks to prove imaging, and of course, discuss just the common pitfalls that we see during the first trimester, specifically the detailed first trimester, second, and the third trimesters. So many of you that are joining us today may be just learning how to actually start scanning, and also many of you are also advanced imagers. So you really have this exposure here. Image optimization, as basic as it is, really truly makes a difference in your screening, and that is by producing good quality imaging. So, image optimization is dependent on the transducer selection. You want to choose a transducer that provides the adequate penetration and as well as providing the high resolution and as well as image presets. It's really important to achieve a high frame rate as this will improve both your temporal and detail resolution. Overall, these two factors that we see here, transducer selection and your image presets, requires a fine balance, and this is what helps produce your high quality image. So, of course, starting with the transducer selection, which is really critical. So, one of the few things that I've learned with transducer tips is a low frequency transducer does not always equate or equal better visualized image. And I've observed this, especially when training sonographers or even working with fellows or learners in general. The first thing that they tend to grab is the low frequency transducer. Understandable if that is the only transducer that you have, but if you have a high frequency transducer, this will certainly provide better detail resolution. And of course, with transvaginal imaging, this is certainly helpful for the first or early second trimesters, even in the third trimester. So all transducers have different operating frequencies and capabilities. High frequency transducers, they produce better detail resolution, but of course with limited sound penetration. So here you can see as an example of a high frequency. This is certainly helpful for evaluating the first trimester, the second trimesters, and really also even in the third trimester. I always try to encourage many of my sonographers is to always start off with your high frequency transducer, make that your workhorse probe, and obviously if imaging is subpar, then you certainly want to move on to your low frequency. Now, of course, with low frequency transducers, this is certainly essential for your elevated BMI patients, the late second trimesters, third trimesters in a setting of polyhydramnios. So you have to keep in mind how far that beam is actually traveling and how much that beam will get attenuated, especially in cases with rib shadowing. And here's just an example of a 23-week fetus with a patient BMI of 55. Notice that we have utilized a low frequency transducer in which you could actually visualize the heart situated deep in the uterine cavity. This allows for better penetration and decreased resolution, as you can appreciate here. Now, how about with transvaginal imaging? So this is certainly helpful or maybe used in the first trimesters or early second trimesters in the event that there is even a suspected fetal abnormality or difficult imaging due to maternal body habitus. This allows you to decrease the imaging depth and provide optimal imaging, especially in early screening, but also certainly trying to assess the lower uterine segment in cases where you're for assessing for placenta location, especially when you're suspecting placenta accreta. It's really certainly helpful and is evaluating the maternal structures. So here's just an example of a case. This is a detailed first trimester, which we actually perform routinely at our lab in San Diego, California. We do this anywhere between 12 weeks and 13 weeks and 6 days. And we always typically take a look at these fetuses, especially if we look at the heart, as we try to improve our screening for congenital heart defects. We utilize color Doppler. So here you can see in the example grayscale, and this is part of our required clips that we want to take a look at. So of course, when looking at the 4-chamber in grayscale, you want to assess pretty much similar to what you assess during the detailed anatomy, which is done anywhere between 19 and 20 weeks. Here we could actually assess the cardiac access. We could take a look at the position of the heart within the chest. But also we want to be able to see a 4-chamber, right? But this, of course, looks suspicious. So I'm curious to see what you guys actually suspect. Does this look like a normal first trimester or detailed first trimester heart to you? And let me know what you think. And of course, when we turn on color Doppler, this certainly tries to confirm whether or not we're able to see both right and left side of the heart. But what do you guys think here? It appears that there seems to be one side filling, right? And this is just an example on my upper right hand, just showing for comparison of what we should be able to see. So of course, what should be our next approach? Well, we're going to go ahead and move on to transvaginal imaging because we are able to assess the structures clearly and, of course, bring us closer to the structure of interrogation. So we optimize by using transvaginal imaging, optimize our grayscale settings, and this is actually what we see. So now that we determine situs transabdominally, here you can see the spine. This is the left side of baby's left side, as well as the right side. And of course, you could see what looks like to be a diminutive right ventricle. And of course, this confirms with the use of directional power Doppler to show if there's any possible inflow, but we see no filling on the right side of the heart. So this patient was ultimately referred to pediatric cardiology because we were able to identify these suspicious findings, and the fetus was diagnosed with a hypoplastic right ventricle. So of course, the use of transvaginal imaging is useful, specifically in case-by-case basis, anytime when you see or when you suspect that there is an abnormality. So ultimately, it comes to choosing the best transducer for your ultrasound. So here is a 20-week fetus with a BMI, patient BMI of 40. Notice with the high frequency, I could really appreciate this beautiful profile view that patients love to see. We could actually see the skin overlying the bone here really well, and as well as the nose, the profile, and lips and chin. However, if I make just slight adjustments, even with shifting to a low frequency transducer, I could really see beyond that. And here you could appreciate the corpus callosum, the cavum septi pellucidity, and that nice looking vermis, which is the posterior portion of the cranium. Because again, here you're allowing yourself to really assess more than just surface features. So how about, what I explained earlier about temporal resolution, which is part of your basic settings, and as well as detailed resolution. So what exactly is temporal resolution? So this is certainly the factors that play a big role in 2D image optimization. So by definition, this is the ability to accurately locate moving structures at any particular instant of time. And what do babies do? They move all the time, especially small, fast-moving structures such as a heart. It has been recommended when imaging the fetal heart, you have to at least maintain a high frame rate of at least, I would say, anywhere between greater than 30 or even greater than 50 beats per second or frame rates per second, especially in the setting of advanced imaging technology. So these are the factors, the technical settings that affect your detail resolution and your temporal resolution, such as your transducer selection, which I did explain that. You have your depth and your sector angle, and as well as your zoom magnification. Now, temporal resolution is determined by the frame rate, and these units are expressed in hertz. Now, the better the detail resolution, the better the temporal resolution. So let's go ahead and try to do that with these examples. Okay, so this is the first image that you see once you place that probe on top of the paternal belly. So How can we actually improve this image? But before we move forward, let's go ahead and just take a look or take note of this frame rate that you could see right up here. And it's usually placed on your upper right-hand corner. For certain system units, it may be placed on top, but all the ultrasound output, or actually all the displays should actually display the frame rate. Now, as I've mentioned, increasing the frame rate also improves temporal resolution. So let's aim on doing just that. So first, what we want to do is get rid of this unnecessary depth and make sure as well your focus is at the region of interest. So I call this step depth and focus. So depth. Now, what happens is when you have excessive field depth, this reduces the frame rate and may lead to compromise in image quality. So I always recommend that this should be actually your initial step. So once we've decreased that depth and adjustment, notice now that our frame rate has improved and now has increased to 41 Hertz. Now, what else can we do to improve our temporal resolution? So I'd love you guys, if you had the opportunity, please put in a chat. Paul, unfortunately, I'm not able to see it on my end because I'm using a MacBook, but just want to see some engagement too as well to some of our audience. So let's go and get rid of this unnecessary width, and I call this step sector angle width. Other names that many of you may know this, it's called sector width or field of view. This affects the lateral resolution, and reducing the sector angle width increases lateral line density, improving image quality. And as you could see, there's a significant difference with that. Notice how our frame rate now has tripled from the initial, right, when we first started, to now 63 Hertz. So what else can we do to further optimize this image? Let's get rid of this unnecessary near field and far field space, and of course, magnify to our area of interest. So I call this step zoom magnification. And the reason why I really included this as part of my optimization talk was because when I first started in fetal imaging, and I worked closely with a fetal radiologist who happens to be my mentor, she's Dr. Dolores Pretorius. And the first thing she said to me, she was like, Michelle, why are you producing these postage stamp images? I can't really see anything, which is true because obviously it makes a big difference when you magnify, right, to your area of interest. So now we've applied our steps such as depth and focus, your sector angle width, and zoom magnification. Notice that your frame rate is at the best as it could be, which is 63 Hertz. You can appreciate the cavum septi pellucidity. You could also appreciate the frontal horns, the third ventricle, and all these structures which we could not see previously, or probably did, but not as well as we did with this image optimization. But what else can we do to further optimize our next image? Well, I call this last step enhance. And enhance, by definition, is to improve or further improve the quality of your image. And this is done by making small adjustments with the current settings that do exist on all your ultrasound machines. And that one is of your dynamic range. So demonstrating the left ventricular outflow tract, demonstrating in 2 different dynamic range settings, and narrow dynamic range, which produces less grays. We can appreciate the heart structures better, sharp and defined in comparison to a wide dynamic range. Therefore, cardiac structures are better visualized with increased contrast, and you could clearly see the difference here. And you could appreciate this left ventricular outflow tract. Notice that you could appreciate the valves as well, and notice the border definition with just doing those simple steps. Now, how about looking at fetal kidneys, right? Especially with the current machines, at times, I mean, the resolution is great, but sometimes the echo textures can get blended, right? So what I found really helpful, here you could see there is a wide dynamic range looking at the kidneys, almost blending in with these specific structures that surrounding kidneys. However, when you narrow that dynamic range, you could actually appreciate the little bit of fluid that accumulates in the renal pelvis, which pop out, as well as the borders. You could appreciate also the renal parenchyma. So really increasing for more contrast and decrease for more gray shades, especially when looking at fetal kidneys. And there you could actually see it. So how about speckle reduction imaging? And I include the different manufacturer names here for those of you that utilize different ultrasound machines of what this may be called. Now, what this does, it eliminates speckle, and weak signals and strong signals are enhanced and brightened. And this actually provides a smoother, cleaner image. However, when looking at the fetal spine, especially in the sagittal view, I really like it when we actually turn the SRI off. And here's just an example of showing SRI on. Notice that the lateral resolution somewhat gets distorted, where it's actually morphing the spine elements together, where you could see a line, and it's really can be tough to actually count them. However, when you turn the SRI off, you could actually see those distinguished elements enough to actually pair them. So give it a try and let me know what you guys think, especially when it comes to bony structures. Also, when looking at the detailed first trimester, I don't know many of you, if any of you guys are performing the detailed first trimester, let me know if that's something that you're performing in your lab. Again, think of it that this is a smaller fetus, but really similar to what we try to assess during the detailed second trimester. In the detailed first trimester, we assess the spine for any type of abnormalities, as well as bony abnormalities. Here you could see, just looking in a coronal view, how you could really appreciate the rib bones. You could actually appreciate these elements within the spine all the way to the distal edge here. So really turn the SRI off when you're evaluating the spine in the sagittal view. And also looking at the extremities, and shout out to any of my sonographers here from San Diego who are on. This is one of their favorite things to do. They start to count they start to count the toes and also the fingers. And when you turn SRI off, you could truly appreciate these limb buds. And I would have to say, because we've done this and really carefully taken a look, we've actually identified many of these muscular abnormalities with the long bones, as well as taking a look at any possible abnormal hands or digits when you turn that SRI off early on during the detailed first trimester. So give it a try and let me know what you think. How about scanning in different tones? I'd like to know those of you who love scanning in your different tones, and let me know what's your favorite, because I don't utilize it. I only utilize it when I'm looking at specific structures, but my sonographers love to really to scan in different tones, especially when it comes to multiples, especially when it's looking at specific structures. And here again, it's just showing looking at the four chamber with different types of tones or different color mapping. So, people often use this and it helps to pick up any subtle differences in echo texture that are difficult to see in grayscale. And you have to think about the human eye. We are so used to looking at some colored. Actually, we can detect more structures when we're looking at things in color. So this may sometimes help pronounce, visualization of small, delicate structures such as the valves or even the walls of the heart, which can certainly be helpful. Also, in looking at, this is just showing an example of a sweep going through the diaphragm. And again, you could appreciate the echo texture just by using this different color map. You could appreciate the lungs. You could actually appreciate the diaphragm demarcation that you could see here, as well as bowel. So really give it a try and let me know what you think. So I know there's many steps that we talked about when it comes to optimizing and just your grayscale imaging, and I tried to simplify this a lot, especially when I try to train others when it comes to scanning. So we spoke about the first step, which is depth and focus, sector angle width, your zoom magnification enhance, and I call this the DAYS technique. So really applies the DAYS technique before anything. Consider this this will be like your first step to optimizing. So this would be before you apply color Doppler, before you utilize advanced imaging to truly enhance your image optimization. So now we're moving on to producing good image quality, and that's by optimizing your angle of acquisition. And this is by utilizing your angle of insonation, asking yourself, what is this? What is it that you are actually evaluating or interrogating? And how we could optimize our views is by utilizing the entire maternal abdomen, as well as optimizing fetal maternal positioning, which is key. So here's just an example of a case. Here you could see where the fetus is lying is towards mom's maternal left. Just take a look at where my probe is actually at. And this is what we actually see. Here, there's a lot you could see. Here you could see a normal right side and left side of the heart. So you look for symmetry. You could actually appreciate the pulmonary veins really nicely in grayscale. You could certainly see the valves opening and closing. But as we were scanning this, the sonographer told me, like, I see what looks like to be a potentially inlet VSD. And reason being is, what do you guys actually see here? What is the one thing that strikes you as you're looking at this four chamber? And ask yourself, is there offset? So here, this should be like your first clue. So what we did is we tried to optimize my angle of incidence. So we went over towards the maternal right and angled upwards. And this is the view that we got here. So really makes big difference, especially when it comes to optimizing your angle of intonation. And of course, you could see this is truly an abnormal heart where utilizing your different scan planes can truly change, right, what you're looking at. So again, utilizing the entire maternal abdomen and of course, the different scan planes. So this fetus, of course, as you could see, is a classic features of an atrioventricular septal defect. In diastole, you could see that huge hole in the heart. And of course, with color Doppler, this confirms a single channel of blood entering the ventricles over a common AV valve. So again, optimizing your angle of intonation, and easier said than done, but it is possible, right? To really try to get the views, especially when you are confirming a defect or not sure. Take a look in different scan planes, and that could truly change what you're looking at. So how about looking at this view here? So here's just an example of a case. A patient came in just for routine imaging. Here you could see in the four-chamber view as well. So nice, proper apical four-chamber view. You could see those AV valve offsets beautifully. And then the sonographer turned color Doppler, and we see a lot of bleeding on here. And this is where you start to get your suspicion, is there a possible VSD? Especially that you're actually directly parallel to the interventricular septum, and you see these striations that are present there. I want you guys to take note of the velocity scale, or the PRF, which is at 6.0, and of course, utilizing a wall motion filter because it's really critical. Technique is key, and as well as acquisition. So ultimately, this patient was, or the physician called it a VSD, and ultimately patient was referred for fetal echo. Of course, patient is nervous, high anxiety, really afraid, don't know what it could be. But I wanted to ask the audience, what could you have done differently here? And feel free to put it in the chat. I'm not able to see, but I guess we could go back later, Paul, to what's in the chat. So of course, one of the things I want you to take note of, this is an incorrect angle of intonation. So you have to ask yourself, is this the proper way to evaluate for any ventricular septal defects? Absolutely not. So one is when you're parallel, when the beam is parallel to a structure, this is where you can cause these dropout, these artifacts, and you could see these striations that are right there. And two is with color, it's all dependent on technique. Of course, you can see a lot of color bleed, so that's not how you evaluate. And I'm going over to the next slide here. So a patient ultimately went for a fetal echo 1 week later, and we actually reported a normal fetal echo and noticed that the technique is appropriate for how we interrogate for a ventricular septal defect. The beam should be perpendicular to the septum, right? I really want to ask yourself, what is it you're trying to interrogate? And now we lowered the velocity scale, which is around the PRF's 2.4, which is appropriate for looking and assessing through both within the chambers to ensure that there is an intact septum. So really optimizing your angle of intonation. Ask yourself what you're looking for. If you're looking at the interventricular septum, you want to be perpendicular to the interventricular septum. If you're looking for the assessment of the AV valves, you want to be perpendicular to the AV valves. And here's just an example of another case. And I know I love to show a lot of old clips, but not many people have new machines. So this is the prime example I'd like to show. So here's a fetus, four chamber, came in for anatomy scan. I just wanted to show that this is a four chamber that we did see, 23 weeks and 5 days, and we cleared it. And then here we could see that there's a normal, obviously interventricular septum. The heart looks appropriate. It's about a third of the chest that you could see. Access is perfect, and this ended up being fine. Patient came back again at 34 weeks and 6 days for routine imaging. And usually that's kind of standard protocol. If we have no suspicions, have the patient come back just one third trimester scan. And this was the 4-chamber that we saw, which looked actually pretty normal. You could see the valves opening and closing. Patient did come back to us again through the labor and delivery. And of course, typical standard procedures. Anytime we have someone that comes through there, the sonographer would take a look at the fluid filled structures, kind of ensuring and also documenting the heart structures that we could. And here we're able to get the view. And this is actually the same patient. So this is 35 weeks and 4 days. And I want you guys to tell me, what is it that you guys actually see here? So notice how the angle of inclination has changed. We are perpendicular to the areas that are appropriate for us to interrogate. And it's one thing that we noticed that we did not notice previously. Here you could see that there is an abnormal valve insertion, right? So we all know that the tricuspid valve should be more apically offset in comparison to the mitral valve, but this is a bit too much, right? So this, of course, fetus was diagnosed with an Ebstein's anomaly, and of course showing with the use of color Doppler. Here you could appreciate the severe tricuspid regurgitation. In diastole, you could show that the color shows normal AV filling, and in systole, the severe TR, regurgitation jet, which is actually in close proximity to the apex. So again, ask yourself, what is it you're trying to evaluate? If you're assessing for AV valve offset, be perpendicular to the offset. So now a little bit too much of the heart, but let's go ahead and go back to the detailed first trimester. So how many of you guys actually look at the retronasal triangle? So looking at the retronasal triangle really improves the detection of assessing oral facial clefts. So looking at this retronasal triangle, does this look normal or abnormal to you guys? And I don't know what's going on in chat, but feel free to put it in here. And here it's kind of looking more of a coronal face. So of course, want to keep in mind that this beam is parallel. And this is actually a pitfall. And of course, when you're optimizing the view to where you really want to assess, and this is having the beam perpendicular to the primary palate, which is actually here, this is appropriate for assessing the retronasal triangle. So again, this image here looks suspicious for a defect on the palate. This is, of course, due to the hypoechoic dropout. But if you notice again, like I mentioned, the beam is parallel, right? Parallel to the structure, so you will have a dropout. And of course, as we improve our angle of inclination, you could see there's actually no dropout, and this is actually the same patient. So of course, this can lead to many errors and a misdiagnosis. In order to avoid this pitfall, optimize your angle to structures and being perpendicular. And how do you actually get the retronasal triangle? And it's fairly easy. And for those of you that perform detailed first trimester, this would be helpful for you. You want to start by obtaining a mid-sagittal view, as you could see here, and that includes the nasal bone. And then you want to rotate your transducer about 90 degrees and tilt the orientation to include the frontal process of the maxilla, right? As you can see actually here, forming that triangle, and a primary palate in the same plane. And note that the ultrasound beam is perpendicular to that primary palate. Here you can see that contiguous line there, which that's showing that's intact. And here again, it's just showing a normal structure. Oops, went a little bit too fast, but this consists of your retronasal triangle. There's the primary palate, maxilla that you could see here, the two nasal bones, the lateral body of the mandible, as well as the mandibular gap. So what exactly is the angle of inclination? For those of you who are still getting, those that are new to ultrasound too and learning how to scan, this is the angle of the ultrasound beam relative to the tissue or organ of interest. And this is such a very helpful demonstration of that, showing that if you are less than 90 degrees and even greater than 90 degrees, you'll notice that you will actually have these weak echoes that reflect back. So this is what causes your artifacts, causes you to really not get that true integrity of a specific structure that you're looking at. However, if you are directly perpendicular, here you're going to have those strong interfaces bouncing back to your probe, and this is where you're able to see structures beautifully. So again, ask yourself, what is it you're trying to evaluate? All right, so now moving on to this too. Here's another example of looking at the pulmonary veins. And this is something that we do routinely, even as part of detailed first trimester. And here is just a fetal comparison of both the grayscale and as well with color Doppler. You can see normal 4-chamber here. I can see these pulmonary veins as they are connecting to the left atrium. They show like as these slit-like structures that are present here. However, notice that as we're trying to turn on color Doppler, we don't see any filling. We could see these slit-like structures, but why are they not filling all the way? And I want you to take note of the low velocity scale, which is about 2.3 kilohertz, and a low wall motion filter. So our technique is appropriate, our color Doppler technique, that is. However, this is just due to, again, an incorrect Doppler angle. So you have to keep in mind, and this is actually the same fetus, is that in these orientations, you have to keep in mind, going back to basic ultrasound physics, the course of blood flow should be nearly, if not completely parallel to the angle of inclination to really show the filling of these vessels. And all it is, what I'm doing is obtaining or I would say manipulating my beam, even if it means starting on top and moving over towards mom's lateral side. And here I'm able to see those beautiful pulmonary veins as they're draining into the left atrium. So really, again, keep in mind when you're looking at blood vessels is to optimize your Doppler angle to be parallel, right, to the angle of incidence to see blood flow. Okay, so now how about optimizing maternal position? We spoke of that, but I also wanted to include, especially with high BMI patients. And I think this is critical to mention because with these, with high BMI patients, we also want to learn how to scan smart, utilize all the tools in our fingertips. And these are the patients that really need, right? They really need the screening. If we're not able to identify what we see, how can we actually improve these outcomes? So really optimizing your positioning, utilizing the tools that you have with your ultrasound machines can really help. And here I just wanted to show the example of one is having the patient scan with a table flat at 0 degrees can sometimes be helpful. Here showing a table with the semi-Fowler's 30 degrees. You notice how there's a little bit of excess tissue that tends to drop. It doesn't help that sonographers really placing, at the areas where they have the thickest adipose. But however, if you have the patient lay flat, really starts to improve the distance between the probe and fetal anatomic structures as some of the excess tissue can actually be equally distributed right on top. So really thinking about that. Another helpful tip is having the patient scan in lateral decubitus. Obviously, if you scan above the excess tissue, this can result to injury, and this is due to the exerted pressure that sonographers can push. You have to keep in mind that the probe only penetrates a few centimeters below the skin. Everything else beyond that will be exerted pressure from the sonographer. So really keeping in mind to really optimize. And this is having the patient turn over towards the side, having the excess tissue falling to the left side can really help optimize and decrease the actual distance between the transducer and the probe. And here's just showing an example that I used previously, 23-week fetus with a BMI of 55, utilizing a low frequency transducer. This is with the patient on her back. Notice that, of course, there is that increased distance, about 6.4 centimeters. There's degraded imaging resolution. We could see the heart, not enough to really clear it as much as you want to, or really gaining that confidence. Doesn't help there's an anterior placenta. But when you have the patient turn over to her side, notice how much that transducer, the attenuation that's going through. Technically, this is 2.7, that's what's in tissue, but here you have that adequate fluid, but enough to actually clear the heart views, right? To really get that sweep from the 4-chamber to 3-vessel trachea view, and to really demonstrate that this, fetus does have no significant congenital heart defects, which we would have to send out for referral. So really utilizing those techniques. Another helpful technique, I would say, is sometimes scanning underneath the excess tissue. Really not advised because really when you have that excess tissue and a sonographer scanning, and especially if you're solo scanning, this will put a lot of pressure on your wrist, and this is what causes injury. I would say request extra assistance to avoid the injury. Sometimes the patients are actually helpful to really happy to help and really assisting with that. Again, optimization is key. Really apply the DAYS technique. Now, when you are scanning underneath the excess tissue, one of the things that's really helpful is try not to stay in one plane or one area within the abdomen. And here's just showing a 4-chamber, what we're able to get. Obviously, there's not a lot of that adipose tissues on there, but enough you could see the 4-chamber. However, if you slide the transducer to a specific area within the maternal belly, sometimes you could get, the proper interface, which allows you to see specific planes. And here you could actually see this is the same patient where you could see there is truly right and left heart. As well, you could actually appreciate the Coumadin ridge that you can see within the left atrium. So utilizing just different maternal planes, utilize the maternal abdomen to really get the views that are needed. And how many of you do scan looking through the umbilical region? This is one of the planes that really has helped me, especially when I'm performing fetal echo in a technically difficult scan, which involves a high BMI. And the umbilicus or the area surrounding umbilicus has the least, I would say, dense tissue. And this is actually thinnest. And I would say you would probably get the most optimal views within this area. So really give it a try. And this is an example of a fetus or at 22 weeks and with a BMI of 49. And here I could see a 4-chamber. I could also appreciate the pulmonary veins and get the specific views that I need. Also helpful, what I've learned from others is really using the transvaginal approach with the obese gravida. So utilize the umbilicus region, really helpful, especially in a detailed first trimester, if that's something that you perform routinely in your lab. Second and third trimester, looking at the intracranial or distal spine structures, especially when they're in the third trimester, really helpful for performing neurosonography, if that's something you have the ability to do. And the key is mainly it decreases the distance between a probe and a fetal structures, allowing you to view optimal structures, right? Other tools that are present on your ultrasound machine, especially with the current improved ultrasound imaging, and industry is really working hard, to make it to really support us and how we could improve outcomes, right? So it's what we call the adaptive image enhancement tools. Sometimes this can be called augmentation or adaptive signal processing. Depends on what your unit or your ultrasound unit may call it, which dynamically adjusts the signal gain and penetration to improve visualization in challenging imaging conditions. So this really improves the attenuation, right? Especially with deep imaging targets. Here's just an example of an adaptive imaging enhancement tool. Without the imaging enhancement, when you have a lot of attenuation going through, right? Going through the layers, as you could see here, through skin, adipose tissue, as well as placenta, and of course going through bone, you notice your image tends to get dark. But with the adaptive imaging enhancement tools that are present on the current ultrasound units that we have, especially the modern day ones, have an enhancement tool, which really enables you to see beyond, right, the fetus, as well as seeing the posterior portion here, where enough you could see maternal structures. So that's something that if you haven't used, please give it a try. And I wanted to include this too, especially utilizing with color Doppler, especially that I'm including my optimization tips for obese gravida. Just showing you an example of the tools that are present on what we have. Here's an example looking at a 22-week fetus with a BMI of 49. When a sonographer turned on color, you'll notice that we could appreciate what looks like to be a 3-vessel trachea view, but notice that there's a lot of aliasing, right, and turbulence going on in this area. And it makes you wonder, is there a reversal of flow that's going through this area? Is there some type of pulmonary valve issue? You could see a little bit of the transverse arch, but you're not sure. So really hard to see, right? So this is the sonographer, of course, really tried to utilize all the tools. Of course, a low frequency transducer was used. For 2D imaging, the scale was lowered, but produced the aliasing. Color was not filling properly. but there is certainly a technique that we could utilize to really adjust this. So when you look at your settings, notice that the flow frequency, the color flow frequency, which is in your sub-color menu, was set to mid. Now we want to adjust that. And how it's done is by adjusting this manually when you go to the sub menu to allow more color fill. And I'll go ahead and kind of explain that to you in my next slide. So when utilizing color Doppler in an obese patient, you notice that color flow isn't filling. This is due to the attenuation of Doppler signal by the increased imaging depth. In order to strengthen this signal, you can go to your color submenu and lower your color flow settings. And it's just done by easy of that. So just like grayscale, color attenuates. So when you have a high BMI, that color is also going to attenuate. So sonographer did that. We adjusted the color submenu and notice now that the color Doppler flow frequency is now set to low instead to mid. And because of this, the velocity scale increased to define the color. So it increased the Nyquist limit, and there's now adequate filling of the vessels. And here you could see that there's normal smooth laminar flow going through the pulmonary artery as well as the aorta. You could appreciate the nice V configuration, which is left to the trachea. So this is a definitely left aortic and ductal arch, enough to actually clear that. And this again is just showing the example between the two when really optimizing and knowing the tools that you have present in your fingertips, like knowing your machine and what tools they have will really help optimize these settings. All right, so now we're moving on, which brings us to color Doppler image optimization. Looks like I only have about 50 more minutes, but we'll try to get through this. So really key is to apply the proper
Please take your
technique.
time. Take your time. You have all the good time.
Okay, good, Paul. So again, applying the proper techniques and tools. And I have to admit, this is the area where I see the most errors. These are the overcalls, right? So really, you have to learn how to apply the proper techniques and tools, especially when you're looking at the heart, right? So when you're looking at this four chamber, really easy to suspect, right? Is there a ventricular septal defect? Is there a mitral valve tricuspid valve regurgitation? I mean, would you guys actually clear this? For me, absolutely not, right? So of course, this shows just a clip of an improper low velocity scale when it comes to evaluating the atrioventricular valves, right? So in order to correct this, you want to adjust your scale to a high velocity scale. Here you can see is just an example of a high velocity scale of about 6.0 kilohertz, which is appropriate for interrogating the AV valves. And here you could actually appreciate smooth laminar flow. And you could also see that there's no overlapping along the interventricular septum. Now, how about looking at the outflows, right? We have the high velocity scale, which is appropriate. These are the settings that are present here. This is looking at the left ventricular outflow tract. And here you can see color overlap going through the interventricular septum. Again, really easy to suspect. Is there a VSD? Is there a perimembranous? What is going on? I would not clear this because of due to all the color bleed. And that's because of the color overlap that you see there. And here you have the color gain is set to high. So what you could do is, of course, adjust it. And this is lowering down your color gain until you could actually see the grayscale area, which is key, looking at those borders. And here you could see that there is no color overlap. So again, really critical, especially to optimizing your color Doppler. And ultrasound industry is really, they are really trying their best to how we can improve color Doppler image optimization. Many of their settings are really good, but at times you need to understand these manual manipulations, especially in a setting of a difficult case. So especially with high BMI patients, how's the positioning? So really understanding this will really help avoid these overcalls. And here's just a helpful velocity scale chart, which I kind of go by in terms when it comes to looking at the heart. High velocity scale, so anywhere greater than 50 centimeters per second, I would say, is looking at the AV valves, your semilunar valves, the great vessels. Low velocity scale, anything less than 30 centimeters per second. And when I say 30 centimeters per second, I'm talking to the velocity scale that's present on your upper left-hand corner when you're scanning as there. Obviously, this will affect also your PRF once you adjust the velocity scale. So low velocity scale, look at the pulmonary veins. looking at the low velocity scale such as the SVC, IVC, and of course evaluating the atrial and ventricular septum. You have to keep in mind this is not a set number. A velocity scale is dependent on your gestational age. So of course, as the fetus is further along, advancing in gestational age, you have to keep in mind, the grayscale attenuates, color is going to do the same thing. So you may have to drop it lower than you do. And also, it's depending on positioning, maternal body habitus, because color attenuates, as I've mentioned. So keep that in mind. So how about directional power Doppler? I'm not too sure if many of you have this available in your ultrasound machine. This is certainly a really, highlight when it comes to women's health imaging is having this available. I find this helpful and useful as it helps us identify low flow sensitivity with, especially when it comes to small vessels. Its enhanced definition provides clarity of the margin of the vessels, depicting any size discrepancies, especially when you're looking at the SVC, IVC as an example, and also really helpful when you're assessing for atrial any ventricular septal defects because because of the low the Doppler shifts that's able to provide just low sensitivity. But I also want you to keep in mind of especially when it comes to color Doppler applications, where is it most important and where I feel that it should be avoided. So this is just an example of looking at the aortic arch. I love to use directional power Doppler, especially looking at the brachiocephalic vessels, because it allows me to evaluate this, especially irrespective of right angles. I'm able to see these vessels really nicely. It allows me to see the aortic wall caliber really nicely. But I also love to use conventional color Doppler because why? This is where it's superior, especially for detecting any presence of aliasing, any type of turbulence, any differences in your gradient, right? Any differences in velocity. This is where it's going to be most sensitive. Especially when looking at the aortic arch, ensuring that there's smooth laminar flow throughout from the ascending all the way to the isthmus and as well going to the descending aortic arch. And I want you to point that out in this next clip. This is a very, very old clip. I know it's like a dinosaur clip, but this is a really prime example of why it's helpful. Is showing color versus directional power Doppler. This is a fetus that's affected with severe mitral regurgitation, obviously a complex heart defect that we could see here. The reason you want to be mindful of how you use your color and directional power Doppler, if this is something that's available to you, is that here you could see color Doppler demonstrating the severe, regurgitation and the aliasing and the gradients that you could see right there along the color scale. However, with directional power Doppler, you're not able to see it. It's not really well defined. And the reason for this is that high definition Doppler has shorter pulses compared to conventional color Doppler, and shorter pulses allow for a higher PRF, therefore raising the Nyquist limit and therefore improving what it consists of the aliasing artifact. So you have to really be mindful when you're looking at just these your valves, your heart valves, when you're assessing the heart, is really try to start with your conventional color Doppler. I only use directional power Doppler as an adjunct to what I'm looking at, because this can certainly miss early signs of evolving pulmonary stenosis or any type of evolving valve issues. So really start with that first. However, where do I find this more helpful? And I'll kind of show the little tips with color Doppler this is another helpful tip is balance or priority. So how many of you guys actually use this? So what exactly is this? This allows you to display how much grayscale and color Doppler information you would like to see. And with your balance or priority, this reduces the balance will show grayscale elements within the color box. And again, going back to my aortic arch, which I love to use. So this is where it's helpful to evaluate the brachiocephalic arteries. This is where I use it. And it's looking at the aortic isthmus, right? Because this is what helps us sometimes assess if there's any possible evolving, narrowing of the transverse arch or isthmus, which is associated with coarctation of the aorta. And when I'm actually lowering the balance, this allows me to really have the walls of the heart more defined, in which I'm able to separate both the ductus arteriosus and the aortic arch. And here I could see the actual aortic isthmus and the head and neck vessels. Which brings me to avoid the 2-for-1 special. So those of you who look at the aortic arch, this is where you have color overlap with the ductus arteriosus and the aortic arch. This happens so frequently. It really makes me nervous when I see something like this, where it doesn't help me really see the arch. And what happens in cases of fetuses that are affected with evolving coarctation or possible hypoplastic transverse arch, your ductus arteriosus tends to cover it, and it also with the use of color Doppler, that does not help. So here's just an example of a case. And I was working with a sonographer transitioning into our area of MFM, is getting the required views. And notice this is the view that the sonographer did take. And looking at this, you could see there's a lot of color overlap. Yes, I could see the beautiful SVC. I could see the IVC. I could see that there is definitely a ductal arch that is present, and as well as the descending aorta. I could see head and neck, but I can't appreciate this area right in between the ductus arteriosus and a transverse arch. Too much color overbleed. Anyways, as she was scanning, I, of course, took over and really optimized first. First, I started with the grayscale imaging, and this is actually the same patient here. I went with grayscale imaging, optimize, was able to really define and intently separate these views. So looking at the ductal arch here, you could see what looks like the head and neck vessels. There's the subclavian. Notice that we're looking at the area of the aortic isthmus and that there's a complete narrowing on there. And of course, we utilize Z-scores for a measurement. A Z-scores gives us like the standard deviation for gestational age. Anything -3 or -2, it's considered -3 standard deviation for gestational age. So this was actually a coarctation, or giving that nice or that typical sonographic evaluation or view of a shelf. And of course, with color Doppler, kind of demonstrating this area. So really, that's something to be mindful for, and I'm utilizing actually the balance to see with directional power Doppler to help me identify this area. So how about slow flow or microvascular imaging? I'm curious to know those who are able to use or actually have used this, where it's actually helpful. So this is, of course, one of the things that's really why people don't like to use it is when you turn on the slow flow or microvascular imaging. It's such a really great helpful tool technology that allows us to visualize a flow within small blood vessels, right? But when you turn that on, you see a lot of color artifact, which is, it really won't help me in what I'm trying to interrogate. However, when you utilize the adjusted balance, here you could really appreciate the beautiful SVC as well as the IVC of appreciating these structures with the bicable view enough to ensure that there's no vessel discrepancy, right? When you're looking at these vessels here. And of course, as I mentioned, looking through the aortic arch is a beautiful sweep, just showing from the ductal arch going into the aortic arch. You can see these head and neck vessels utilizing these features. So another helpful with utilizing these advanced technology is looking or assessing for any pulmonary veins during the detailed first trimester. Here you could see beautiful pulmonary veins that are draining into the left atrium here, as well as you could actually see two. And enough you could see the borders or see the indented borders of where the interventricular septum would fall. So really helpful, especially when assessing. Now, one of the things too with utilizing balance, and this is again available on current ultrasound machines and available too with previous older models. So this is there. So again, utilize the tools that you have at your fingertips. We do the detailed first trimester routinely in our lab, and this is where I found it was helpful. So here you could see a normal 3-vessel trachea view. This is something that we assess to ensure there's no conal truncal abnormalities during the detailed first trimester. Here you can see the pulmonary artery and as well as the aorta, making that nice V configuration to the left of the trachea. So again, see the V, which is critical. And here is a case, of a sonographer took the image. This is the first trimester case that was taken. Well, Patient did come to us during the second trimester, and we did identify transposition of the great arteries. And we were just wondering, like, how, trying to see did we miss something during the detailed first trimester. So, of course, in our lab, we do have a comprehensive QA program in which we try to assess, the previous studies to see what we could do to improve our imaging. And the sonographer did show this image, and it's going to keep playing here, but where balance is really helpful. And I think also too is technique is key, especially for those of you who are performing the detailed first trimester. This looks obviously like a really nice V configuration, pulmonary aorta. However, when you reduce the balance to really intently see those vessels, how many vessels do you actually see there? I only see one. And this is actually going back in this case, as these images are still stored in our ultrasound machine, there was actually one great vessel. So this is something, a miss, where it just really demonstrates that how you're optimizing, how your technique and how what you're utilizing or what you're doing is really critical in order to improve the screening process is really the key to screening. There you go. So there you can see that typical boomerang sign, which is consistently seen, or I would say majority of the time seen with cases of transposition of the great arteries. All right, so now moving on to, I guess, say almost the last part of this is where good image quality is really utilizing the advanced imaging applications. If this is available to you, again, industry is really working hard to really ensure that we can get the proper tools. So utilizing your 3D, 4D, tomographic ultrasound imaging, stick glass body, volume contrast imaging. These are some of the examples, but I will not go through all because I don't have the time I'm probably going to exceed the time, but volume contrast imaging, which is available on all your ultrasound machines, even the older models, it performs real-time 3D surface rendering using thick slices. This produces an image of a solid organ or bone contour and shape. And this provides easy visualization of the vermis lobules and fissures, bony structures, which I really love to see, such as the spine, extremities, and fingers and toes. And this, of course, is available on your 3D ultrasound probes. So really take a look and try to utilize those settings, especially when assessing. Here's an example of a 24-week fetus, 4 days, BMI of 58. Here you could see the orbits. I would say pretty decent enough to clear in 2D grayscale imaging. However, when you turn VCI thick slice, you could really appreciate those bony structures. And here you could see how that has improved dramatically. Also, when looking at the palate, here you could see with 2D imaging, I cannot see the alveolar ridge. It's hard for me to actually appreciate the back of the palate, which could be tough, and see all how tough the imaging is. But when you turn VCI thick slice, enough yet you could actually appreciate the alveolar ridge here. And there is actually the lip to see the palate. So really helpful. Another helpful technique, and I love to use, especially when you are scanning a fetus and you notice that there is some irregularity, right? Especially in second trimester, looking at the bony structures, especially in cases such as skeletal dysplasia, or there may be fractures, which are present in features of osteogenesis imperfecta. How this can actually enhance the bowing. And here you could see how this is just a normal for comparison. Notice you could see bowing here of the, both the radius and the ulna in this fetus present with osteogenesis imperfecta. And here's an example of the fractures that are present within that you could see in the lower extremities. Microvascular imaging, I think I did not get to remove this, but this is a bonus slide where it's helpful. I love looking in 2D imaging of the mid-sagittal view of the structures of the fetal brain, especially with high resolution probe imaging. You could see a nice corpus callosum as well as cavum, as there's a vermis, and of course with microvascular imaging. Here you could really appreciate these paracallosal arteries, rostrum and genu that are present especially when you're assessing for brain structures. And of course, 3D rendering, everyone does that. It's one of the most, I think, beautiful highlights that we do with being an obstetric and MFM sonographer. For those parents, really appreciate, right, to improve that fetal bonding. But at times, it's really helpful when you think about it. Really helpful for us to identify, that when especially when you're assessing for any facial abnormalities, it helps us to align, right? If the face and skull can be aligned accurately in standard anatomical planes, enabling objective assessment for fetal symmetry or asymmetry in multiplanar or tomographic or render mode displays. And here again, it's just examples of what we could see of normal silhouette. Here's a fetus that's affected with achondroplasia. You can see that frontal brossing. And here's also a fetus with Treacher Collins. Notice the low set ears and severe micronathia. How many of you guys like to use multiplanar imaging? That's like one of my favorites. And it's so, so helpful. I feel it's underutilized, but it's something I feel like many of you have to learn. And in order to learn, you have to keep doing it, right? I feel many people, they stray away from 3D, utilizing the 3D applications or types of advanced imaging because it takes too much time. Well, how are you supposed to learn? You have to give the time. So even if it means scanning a patient every day, saving the volumes, and when you have time, manipulate those volumes, it could really help you to be proficient. Because when you encounter that abnormality, this is where it's going to be helpful, right? So this is an example of looking at the fetal brain, 3D multiplanar. So when you get that volume, and what multiplanar does is that it allows you to visualize the planes in all or three orthogonal structures. You have the sagittal view, the coronal view, as well as the axial view. And here you could see, especially when the fetus is such a tough position, it'll help you. Here you could see, nice mid-sagittal views. Hard to see the face because baby, depending what it's laying on, but enough when you align these structures to where they're be in complete alignment, you could appreciate the cavum, the corpus callosum, that beautiful vermis that you could see here. And this allows you to see these mid-sagittal view structures such as the vermis, the corpus callosum, and again, the cavum septi pellucidum, especially if you're suspecting. The vermis, which is, I always love to say it's a cute structure because it is. It kind of reminds me of a kidney. I don't know. I feel like sonographers here, we always compare everything to an object, food or fruit, whichever, but enough to keep that, I guess you could say pattern recognition. Here's just an MRI, which is really helpful to see how it kind of also reminds me of a tangerine. I don't know if you guys ever ate this back in the day. Really bad for you, so don't eat it, but it kind of looks like these orange tangerine slices, and that's what it reminds me of to really see the vermis, right? And this is a normal looking vermis that you could see here. And here's just an example case here. Patient came in for an ultrasound scan. Sonographer was scanning. We know what a normal posterior fossa should look like. We know what a normal cerebellum. This is something that we all obtain, especially in the standard imaging as well. As a sonographer was scanning, she saw what looks like to be this keyhole appearance within the fetal head. So it's abnormal. And of course, one of the differentials you want to rule out or you want to get further evaluation is sometimes you want to rule out whether or not it's Blake's pouch cyst versus a Dandy Walker variant. And you could see here, there's the expansion of the fourth ventricle into the cisterna magna, resulting in this large anechoic area, cystic area behind the head, posterior fossa. So certainly this is abnormal, right? So of course, this is the same case, same patient. And we did 3D imaging to really look at the vermis. We actually measure the vermis too as well, and there are nomograms out there to kind of see if it's within, it should be consistent within gestational age. And we did see that the vermis is present, and that is key, right? Whether to know whether or not the vermis is present or not. And here you could see that the vermis is actually present, but it's rotated up and counterclockwise. The pink dot here is kind of showing to where this dot is throughout different orthogonal planes. And this is the sagittal view as well as the axial view. So this, of course, ultimately, patients still had to go get an MRI to really ensure. This fetus ended up having a Blake's pouch cyst, which of course is an isolated finding. And typically these fetuses do well. And there you could see that. And just for comparison, normal and an abnormal. So vermis is present. All right, and lastly, this was just a case. We do detailed first trimester, and this is just kind of showing you the examples, the thought process of what we go to when you utilize all the tools in your fingertips. Utilize the applications that are present on there. So this is fetus at 12 weeks and 6 days, 20-year-old G1, no cell-free DNA screening, so no NIPT, and of course with increased BMI. This is how it looked, trans-abdominal imaging. Here, of course, you could measure the crown rump length, but one of the things you really want to try to assess is the back of the neck, which to assess whether or not there's increased, a decreased or increased nuchal translucency. But here you could actually see that it is increased. So that, first off, does not look good. And the sonographer did get a lot of images too. Since she's close to 13 weeks, we see this area. Usually, the midgut herniation is you're not supposed to see that beyond 12. And here, this has us getting suspicious that this could be a possible omphalocele. There's a 12 millimeter increased nuchal, which is clearly very abnormal here, and of course, a single umbilical artery. So, with all those factors, really has you thinking about, this fetus could be affected with a chromosome abnormality. So, of course, our next step is to do transvaginal imaging. So, again, utilize the tools that you have. So this ended up being an omphalocele here as well. You can see that echogenic area. So the protrusion of some bowel herniation that's out there. And as, of course, looking at the heart, clearly that's something we couldn't see much of transabdominally. This heart looks very abnormal. See how it's enlarged and possible large septal defect that's present there. And as we're scanning through, looking through structures, and I would have to say, many people have asked me if you were to do transvag, can you 100% get the views that you need? I have to admit, with transvaginal imaging, your field of view is limited, and that is the disadvantage. But you can see structures. But how can you optimize this, right? So this is what we were getting. We couldn't it was really tough, especially with how the fetus was lying. We kind of see when looking at the neck, you could see this is a coronal view. There's a little bit of thickening around here, around the neck area, but we kind of still went and moved forward and try to get other views. As we take a look at the lower extremities, the femur looked a little bit irregular here. And we were saying, this could possibly be a fracture because it does not look right in comparison to the right femur. So we, of course, turned on volume contrast imaging, and you could see how you have that large defect on there. And this is where your tools can really essentially help you to really, really confer a diagnosis. So definitely a fracture there. And of course, the way baby was positioned was tough for us to see the head. So we did more advanced imaging. And this is where we did multiplanar, and we also did tomographic ultrasound imaging. So tomographic ultrasound imaging almost produces like a CT-like structures. So once you get that volume, it'll get these slices throughout the head. And what do you guys actually see here? Notice that there is a monoventricle. You don't see the falx. So this fetus ended up being diagnosed with, or actually ultimately sonographic findings consistent with holoprosencephaly. So again, utilize the tools in your fingertips. Can really help you. So in conclusion, I went 10 minutes over. I apologize, Paul, but really understand the key function and controls and how they affect your image. And as simple and as basic, we all learned this in sonography, but the basic functions is what's going to take you to the next level. Apply the DAYS technique, depth, sector angle width, zoom, and enhance. Utilize the entire maternal abdomen, especially optimizing your views, especially in high BMI of where we're able to decrease the probe as well as structures. Optimize your angle of incination. So again, you want to ask yourself, what is it you're trying to evaluate, especially when looking at solid structures, when you're looking at structures such as the heart, if you're looking at the interventricular septum, your angle of incination is supposed to be, the beam is supposed to be perpendicular to the septum. If you're looking at the AV valves, your beam is supposed to be perpendicular to the AV valves. And also utilize the tools at your fingertips. We have all ultrasound machines. Learn how to utilize it. Talk to your rep, ask them what are the other helpful tips, and really learning how to do those will really help you improve, and that is your key to screening. Okay. Thank you so much, Paul, Ultrasound Care Foundation.
Thank you so much, Michelle.
I kind of went over, I'm sorry.
Our I'm really wowed. Like, wow.
So,
And This,
so
this is so, so, so much. Like, this
thank
is so
you.
much. Thank you so
Okay.
much. Thank you so much. I
You're
really don't know
welcome.
how to appreciate you. I really don't know. I don't know how to let you know the impact you have made to us this evening. The much information. I know you are trying as much as you can to be very fast so you can meet up with time. But please, when next we have you, just make sure you take your time as much as you want to.
Thank you. But yeah, let me know if you have any, if anyone has any questions.
Yeah,
I,
I'm going to go through the questions they have.
okay.
But before I go through the questions, I just want to please make announcements. Then I'll go through the questions they have.
Okay.
So to
Okay.
all the participants, thank you so much for attending. Just for an announcement, next month, which is April on the 18th, we'll be hosting another great expert. That will be Badlamidia. Yeah, so he will be with us on April 18th, and he will be speaking on the three vessel trachea view. So I believe that what Michelle has done this evening has done a whole lot of justice for us to go back and see how best to optimize our images. And then when he will be presenting on the three vessel trachea view, we'll be able to relate very well with the images he's producing. And also to let us know that the recording of this webinar will be available on our channel on the YouTube, and the channel link has also been posted on the chat. Please do well to follow and subscribe the channel so that you will be notified when the recording is available. So I'll take the questions they have before I can also ask my own. So earlier on, the chat was disabled, which I wasn't aware, but then I had to enable it. So the first question is, this person said, many thanks, Paris. How best can I obtain BMI and what significance? Thank you. So that is the first question.
Okay. First question is
You,
obtain.
you can
Oh,
see it, right?
okay. It's how to optimize BMI for high BMI patients. Is that what it is? Well, how can you obtain? Okay.
I think the question, because most times when you were training, you were mentioning the BMI to be 49, to be this, having a number. So I think this person
Oh,
is trying
okay.
to know
How
how
can you
did you
obtain?
obtain the
Okay, okay.
number.
That's what
Yeah.
they meant. Okay. So
And
when you
what is
get
the
the BMI,
significance
yes.
of that number?
Yes. So BMI is body mass index. So usually, how do you get that? It's by the patient's height and weight. And there are calculators everywhere. You should have that. There is a BMI calculator online. There's even an app for it. And we doc. And why is it important to document? Well, for one is, well, in the in the United States, it's a very litigious country. What I mean by that is everything has to be documented. We're very and same thing too. I could imagine too, Paul, with sonographers, you have to document the reasons why you weren't able to see specific structures. So whether it is,
Yeah.
so and that sometimes is the reason why we do that. It's also because, as you know, with medical imaging, it results typically in lawsuits. Especially if a baby is born with an abnormality and then something that we thought we saw, we did not see, or we thought it was normal, but it wasn't as clear. That could be, that is just more like why documentation is so important. So, documenting the BMI pretty much signifies of the quality of the imaging that you're able to get. And as sonographers in the United States, we do that because it signifies to the physician, like, this is the quality you're going to get because I'm not able to optimally see. So this is the reasons why these pictures were suboptimal, or this is the reason why, because physicians, physicians, right? They read either they read in another room, so they don't see the person that you're scanning. So I think that's where it's really helpful is just documentation. All ultrasound reporting, I believe, usually they usually provide that. So that is why it's important to document the BMI.
Thank you so much for that. I just hope and wish that one of the body that is actually training sonographers in Nigeria would be in this meeting so that we'll be able to have a standard protocol that all sonographers will be able to use when reporting. Because I'm not sure that everyone does that here in Nigeria, being able
Mhm.
to document the BMI. Yeah, so and with your explanation, I think is a very, very important thing to note on the report so that the physician will be able to know, okay, this is why you are not able to obtain this. All right. So the limitations you had to. Thank you
Yes.
so much.
Yeah, especially when you are reading, if a physician is reading remotely, I think it's good for them. It's more, I would say, realistic for them to know what the patient BMI, especially when you're trying to assess the heart. So I think it'll be understanding for them on their end, like the sonographer was not able to get this, one of the factors being a high BMI. So that's also, I think it's a standard practice for, well, for more, a lot of high risk clinics that I think in the United States do it. I know pediatric cardiologists who perform pediatric or perform fetal echo also report that BMI as a factor for a technically difficult study. So it's critical.
Thank you very much. As you are speaking, I'm just imagining what is going on here in Nigeria. You walk in, the patient just goes straight to the couch and lie down, you obtain your images, and and the person goes home. Okay, so the second question we are having here is how can you rule out mitral valve regurgitation on 2D ultrasound on the grayscale?
Oh,
So
on 2D.
that is
Well, in
yeah.
2D, okay, so regurgitation on 2D, well, it's hard because I mean, regurgitation, well, you can recognize like an abnormal valve sometimes in grayscale imaging because when you look at this excursion of the valves, so again, this is where it's getting into more the anatomy rise. When you're looking at valves, you got to think of valves as mobile thin leaflets, right? So you look at the excursion, you look how making sure the valve is not thickened, you make sure that it's not echo bright because usually those are the signifying clues when you're looking in grayscale imaging. When you see a valve that is lacking excursion, so what I mean that where it's not opening all the way, you want to, of course, your next step is to turn color Doppler because color Doppler really truly confirms sometimes when there is a valve abnormality, and that's the only way to see it. Is to really demonstrate the regurgitation, right? The reversal of flow. And of course, having the proper scale settings when looking at the valve, if you have a high velocity scale and you see the reversal of that flow, then that is abnormal. So that's something to really start to, you have to interrogate more or refer out to high risk obstetrics or refer out to pediatric cardiology who perform fetal echo.
Yeah, just to add to what you said, thank you so much. You can also be able to look at the position of the valves if
Mm-hmm.
they are well positioned, as that can be a marker for you to move ahead with applying your color for regurgitation, knowing the tricuspid and the mitral valve, how they are positioned, and you can also use that to check. All right, so Inshallah, please permit me before we proceed with the questions. I want them to take the poll,
Oh,
then
yes.
we can now proceed with the questions. So please, we have a poll question of 10 questions to use and check how well you understood what Michelle has taught us this evening, this morning, this afternoon. So please, I'm going to launch that. Kindly respond to the poll so that we'll be able to see how well you understood what she taught.
Are you going to play the poll, Paul?
I'm launching it now.
Okay, okay.
Sorry, I don't know. I'm trying to launch it, but it's giving me. Okay, I think.
I think it won't. There's nothing.
Yeah, I'm clicking on the launch, but then okay, maybe I will work on that while we are taking on
Okay,
other
no worries.
questions, please. Okay, so the next question that was asked, okay, so for those asking of the PDF and how you can able to access this, I think I've been able to respond to that and we'll reach out to you via email when the recording is available.
Okay.
Okay, so please, I'm looking out for the questions. Okay, so this question said, if the NT is more than 3.5 millimeter, and we consider high risk of genetic abnormalities of structural issue, what would be the next step?
Well, the next
I
step is when you
think,
measure. Oh, so good. So the
yeah,
next
go ahead, please.
Yeah. So the next step, when you see an NT that's enlarged, really take a comprehensive look at all the structures, right? You really, if that's what you mean, I hope I'm talking about the right. So, looking at the brain, obviously we have a thickened, NT. You also want to look at the heart because obviously increased NT greater than 3.5, the increased risk for congenital heart defects. So looking at the four chamber, and we do at our lab, we do a detailed first trimester. I'm not sure if that's something that you perform, but really like what I demonstrated, taking a look at the four chamber with color, taking a look if there's a three vessel trachea view. And we usually take a sweep from the four chamber going into the three vessel trachea view to ensure that there's proper crossing or obviously more likely what we were able to see at that gestational age. So really taking a comprehensive look. Sometimes, if it's not well seen, if we're not able to get the structures, then we do a transvaginal ultrasound to really look at these specific structures. Certainly, with that, from the physician perspective, usually my physicians would offer like a CVS, so invasive diagnostic testing too as well, invasive testing to really, that's the options they provide for patients. And usually those patients with increased NT, we do what we call an early anatomy starting at 16 weeks. So that's what we do at our lab.
All right, thank you very much. I think I've been able to launch the poll question. I don't know if you people can see it from your end.
Yes, I can see it, Paul.
Okay. So please, the participants in the on the call, please kindly respond to the questions to enable us see how well you understood this optimizing, how well you understood this topic, optimizing obstetric ultrasound imaging. Please kindly let me know, the participants, if you can see it pop up on your screen, kindly respond to the questions. Okay. Um,
I don't know if anyone's responding.
Please, you can still be able to see the pool, right?
I could see it. Can everyone see the? Oh, they said I didn't get a pop up. I could only see it on my end, Paul, but I can't see. I don't think they can see it.
I've launched it, so they should be able to see it. But let me end it and launch it again. Okay, yeah, people are responding now. I
Oh,
think
okay.
someone has started the
Ooh.
response. So please check. Okay, two people. Kindly go ahead and respond to the poll question while we also go ahead with the questions. Um, okay, the next question that was asked is Okay, this one is saying, if there is time, could we please explain again how to properly angle the four-chamber view in patient with a high BMI? Okay, so I think this please, you can watch the recording of this to take the information again, so that we'll not have to stress Michelle on repeating the same thing over and over again. Okay, so this person asks, can you please explain how to obtain the cardiac views? No, please. The presentation is how to optimize the image. So when we have a presentation on the of fetal heart chamber views, and we also have, I think we have a recording on that that was presented by Lachelle Jones. She spoke on some of these, and I also I gave a talk on the four-chamber view, how to obtain the four-chamber view. So the recording of this particular question is available on our channel. Kindly go and view it, and then you can also drop your question on the channel. Okay, so the entry has been responded to. While they are doing their poll question, I also want to ask my own question. So this is just to also help them in understanding. So when it comes to the Doppler sensitivity, when we come to Doppler sensitivity, what are your to-go adjustments for PRF and wall filter when moving from a
Oh,
very high flow vessel like the umbilical artery to a low flow state like the middle cerebral artery?
oh, I'm sorry. Can you repeat that one more time, Paul?
Okay, like what are your to-go adjustments, the adjustments you have to make
Mm-hmm.
regarding the pulse repetition frequency
Okay.
and the wall filter. So we are talking about adjustments to make in respect to pulse repetition frequency and the
Yes.
wall filter when you are moving from a very high flow vessels like the umbilical artery
Mm-hmm.
to a low flow one like the middle
Okay.
cerebral artery.
Okay. So you have to, so obviously with umbilical artery Doppler, it's very easy because once you turn on the color settings, it's the most easiest Doppler to get. But if you're moving from umbilical artery to MCA Dopplers, you also have to think about how small the vessel is. So meaning say if it's smaller, you have to think of the optimization, right? So one is when you're looking at the middle cerebral artery, I usually try to find a circle of Willis. And trying to find that nice circle of Willis, I have to also be kind of angling towards my thalami. So I usually find a nice BPD, a nice typical cranial view of where you would measure BPD. And you want to angle towards where you could see the thalami. And you want to turn on your color Doppler. And usually, with finding the MCA, I like to use a directional power Doppler because these vessels are very small. So there's better sensitivity to detect that. Make my color box small and just focus on obviously the most proximal MCA. I also try to, adjust my color gain enough where I could see the vessels where it's not so much color bleed. So again, you have to keep in mind how small these vessels are. And of course, when it comes to using the directional power Doppler, these auto settings to automatic to low velocity flow, because again, these vessels are small. And from there, that's how I'm able to get the MCAs. And of course, the MCAs is very technique driven. I feel it's one of those where I see the most errors. You have to be important at when you're interrogating the middle cerebral artery. I try to keep it as angle of inclination as zero. I don't even angle correct because you can manipulate because that's where you get the most approximate velocity when looking at peak systolic velocities, especially look at the MCAs. I try to have my Doppler gate at least the proximal third of the vessel, because obviously when you put it to any specific distance from the vessel, sometimes that could affect the velocities, but they are very minor. But yes, Paul, MCAs are very that I have another talk on. So MCAs are one of those where
Yeah,
it's very technique driven.
yeah, okay.
You have to be very careful,
Yeah,
especially. In cases of where depend, if you're assessing for anemia, obviously, or increased peak systolic velocities. So it's very technique driven. So those are like my tips, my helpful tips.
All right. All right. Thank you so much. I will just ask two more questions, not to keep you here for long,
Mhm.
and then we'll look at the full question if you don't mind. Should I go ahead, please?
Go ahead.
Okay. Okay. With the look on the fetal echo, looking at the temporal resolution in fetal echo. So when you are evaluating the fetal heart, I believe you have your preferred strategy for optimizing the frame rate. So like you have mentioned at the past talk in this webinar where you talked about narrowing the sector width and as
Yes.
well as adjusting the focal zone. So how do you really ensure that the optimization of the frame rate is okay without compromising the spatial resolution needed for the outflow tracks?
Oh, so how do I ensure that frame rate? So really, earlier I spoke on the days technique. So following that systematic process, like starting with, and that's what days stands for, right? So reducing your depth, narrowing your sector angle width, and once you get your sector angle width, you want to magnify. So that's zoom magnification. So like really performing those three steps. Enhance is one of those where like little settings that you want to do, whether or not you want to use color mapping, adjusting your grayscale or dynamic range to enhance CETA structures. So those steps specifically, when you follow that in that order, will certainly increase the frame rate. I usually try to, and especially now with current ultrasound technology, the frame rates are they have improved significantly. So industry has been really helping of how we can improve. However, many of these adjustments we still do them. And we want to improve the best that we can to increase that frame rate. Um, and where it's also coming to is that, obviously we have AI technology that's coming. AI is dependent on optimal imaging. Who gets the optimal images? Us as sonographers, right? So that's why I think we'll never be replaced in terms of acquisition. But that's how you can actually increase the frame rate is following the days technique.
Yeah, thank you. Thank you so much. And I think you with your talk now, you actually pointed me to what I wanted to ask in respect to AI assisted biometrics. And with you having this being AI driven in your practice and also moving forward, I don't know what extent you have actually practiced integrating AI. And then if there has been any integration of AI in your practice, have you found these tools like significantly reducing interpreter variability? Does it save time or on the back end? What is your take on it?
So I feel like, I mean, if you think about it, everyone I think is already have been utilizing AI, right? Our ultrasound machines, depending on the type of units you have, a lot of the women's health ultrasound machines have auto measurements. That's AI already. So the auto measurements, like measuring the belly, measuring the femur length, the head. So we already utilize it. Obviously, as you could see, is sometimes when you get a very difficult patient, AI, when you're getting an auto measurement, it'll measure something else that it's not the belly. So to me, I feel that AI is, again, very dependent on optimal imaging. And it's our responsibility and our job to get the optimal imaging, the optimizing, how you say, the appropriate acquisition planes. So that is something that still we are, that is still where we are, as sonographers, that is really our job is to acquiring the optimal planes because you're not always going to have a patient with a BMI of 19 or a really appropriate view, right? Now, the question you asked, Paul,
Yeah.
is how is AI going to be integrated? Well, I feel it's really going to support, meaning to say it will support efficiency. It will certainly support sonographers in terms of having us to hopefully, to improve our efficiency, especially of obtaining the images. But obviously, I feel as a sonographer, despite that AI is there, AI has its flaws. It's not perfect, right? So I think as us as imagers, we really have to, at least understanding the foundations is still very critical because it's not, it's improving and we know it's coming. So how can we coexist with it as imagers? And certainly there is, where we are still very much, trying, again, where we are the ones who optimize the plane of access. So I think it's going to support, and I think it's definitely going to be helpful, especially in outer resource areas that are very tough, in terms of how or what structures they're able to see. So I see the value in it. Now it's really adapting to it. How can we utilize it to make us efficient as imagers, right? So that's coming. There's more to that. So
Thank you so much. Thank you so much, Michelle. I really appreciate you so much, and I'm grateful that I don't know if you can hear me. I really appreciate you so much, and I'm grateful for your time, for all the whole information you have given us this day. And honestly, I pray and wish one day to have you in Nigeria. So, so
maybe
I don't know. I
someday
don't
I'll
know
go to
if you actually
Nigeria.
have if you actually have it in your plan to visit Nigeria at any time in your life. But I think I really love to have you in Nigeria because we really need the help as much as we can get. All right. So on hands-on, because even after the whole even after the whole lecture, even after the whole lecturing, moving the hands to obtain those images are very, very vital. And these are things we really need international experts to help us out with too here in Nigeria. I really look forward to partnering with you moving forward. And thank you so much. So you can take a look at the poll question to see how well they did regarding what you have taught.
Okay, so let's go take a look at the polling here. I know, so it says which factor most directly improves temporal resolution in ultrasound imaging? So of course it is increasing the frame rate. So, oh, did you want me to read that poll? I'm sorry. Paul, do you want me to give the
Yeah,
answers?
please,
Okay.
please go ahead. Yeah, please
Okay,
go
so
ahead.
number one is increasing frame rate. So that's the answer. Um, Number two is when is high frequency transducer most useful? Obviously, the answer is, I'm sorry, I'm not able to read that. It's when you have improved detail resolution is needed. So that is certainly key. And I tried to make these questions really easy, Paul, okay? So uh,
Yeah,
which
you did. You
change
did.
which change usually improves image quality first in a difficult scan? Obviously, as we mentioned earlier, with the days technique, you reduce your depth and you narrow your sector angle width because obviously you can tell that's where you have the significant increase in the frame rate. So if you do those steps and before you do anything, decrease your depth, narrow your sector, and zoom, and then utilize everything else like your color Doppler, this will certainly improve your imaging. All right, and then what is the next one? Number four, it is for low flow vessels such as pulmonary veins, what Doppler adjustment is often needed? Um, Obviously, low velocity scales because it's a low flow vessel, and that the only way to see it is if you adjust your velocity scale to I would say less than 30 centimeters per second. Be able to detect that. So that's really key, especially when you're assessing the pulmonary veins and trying to determine the direction of flow. Okay, so number five is when scanning a patient with elevated BMI, which maternal positioning strategy may improve imaging? Certainly, lateral decube is what we always default to because that is where it's going to actually bring you closer to the area of interrogation. So you want to decrease the distance between the probe and the distance between the probe and the fetus. Okay, number six is what is a major reason color Doppler may not fill properly at an increased imaging depth? Is because, yes, like I mentioned, color attenuates just the same as grayscale. So that's something you have to keep in mind going back to physics, right? As that beam travels down deep, you are going to get a lot of attenuation. So that's why it's key to know that you have these specific techniques and tools to really optimize it, right? Number seven is when evaluating the aortic artery color Doppler, what pitfalls should be avoided? So the 2-for-1 special. You got to avoid the 2-for-1 special. That's where you have the ductus arteriosus and the aortic arch together, and that is a common pitfall that we see, and that's why coarctation or any type of hypoplastic narrowing in the transverse arch is missed. Number 8, what is the best definition of angle of inclination? You guys nailed that. So that's the angle of beam, the angle of the beam, which is relative to the tissue or organ of interest. So you really, again, got to think about what is it you're trying to evaluate and really optimize based on that, right? And also, too, when you're looking at color Doppler, it is the opposite. You want to be parallel to the angle or the Doppler of angle inclination to see the color flow. But when it's solid structures, you want to be perpendicular. When evaluating a suspected VSD, defect with color Doppler, what technical issue can falsely suggest pathology? Of course, incorrect angle of inclination. Like I mentioned, you want to be perpendicular to the septum to assess. And then lastly, it is when evaluating the ventricular septum with color Doppler, what beam orientation is preferred. Yep, you guys got that, perpendicular to the septum. They did so good.
Thank you so much. Thank you so much, Michelle. We appreciate your time. And with this, we come to the end of this session, and we really thank you so much for that.
Thank you so much, Paul. So if you have any questions, I am also on Instagram. Please feel free to reach out. I do the best that I can to
Yeah,
respond.
I think I'm going to include your LinkedIn channel link and also that of your IG on the email that I'm going to send out for the notification so that they can be able to follow you and also ask questions. But if you also want to, on this chat, maybe you can also include it for them to follow right now.
Let me see here.
Why I also do.
Let
Yeah,
me
take
put
your
here.
time to do that.
Okay, so this is that's my IG, and then my LinkedIn is on Michelle. Just you could look me up, just Michelle Perez. Paul, I think someone asked if there's a question here. It says, do you have any practical tips of technical recommendations for better visualization of the fetal cranial sutures? That is a great question. So when you're looking at the cranial sutures, obviously, what I feel helps me the most is utilizing advanced imaging, such as multiplanar rendering. So it's available also with the older machines, and you just have to go into skeleton mode, which is really helpful because this is how you identify if there's any possible premature closure of the sutures, if that's what you're trying to assess for in cases of craniosynostosis. Again, is really utilizing those advanced imaging. So 3D multiplanar render mode is what I use to see. I know in grayscale imaging, it's hard to see. You can see it, but I feel like I can see it better when I perform the 3D advanced imaging with the cranial sutures.
Okay, thank you so much for that. Please, you do well to follow her on Instagram and on LinkedIn, and we hope to bring Michelle again, Michelle again. I remember last year when I talked to you about presenting on placenta, and you said that you're going to have a talk on that this year. So hopefully you will agree to be here again to talk on that.
Thank you so much, Paul, for having me. I hope this was a great presentation. Again, it's very basic, but I feel like it's key, it's critical
No, it's a
to the tools that we use. Yeah.
it's a very great presentation. It's a very great presentation. Thank you so much. Thank
Thank
you.
you. Thank you,
So,
everyone. Have a good evening.
see you next time.
Bye-bye.
All right. Take care. Bye.